This is where one of those x-rays, well, I always say, like, when you've got a non-dedicated view of something, right, don't look for subtleties, because what can happen is that sometimes people will worry that there's an abnormality in a non-dedicated view, but they're really looking at the most obscure, not quite 100%, but you've got to look at, when you're looking at non-dedicated images, go for the 100%ers, right, where it's 100% not quite normal. And then you go for the dedicated view if you're a bit iffy about it. But on this one, I think you can call the abnormality without being too worried, right? And it's all to do with alignment of a specific region. But for those of you that haven't seen it yet, don't worry. I am going to go through this. So we've got the head of the humerus, and you've got your glenoid that is sitting there. I just want to make sure, can everyone see my mouse? Because I remember once I was doing these talks and no one could see my mouse and see where we are. Can someone just tell me whether you can see my mouse? Yes, you can. Good. Okay, that's great. Because I think someone later said, "Oh, I can't see your mouse. I don't know where you are." So you've got your glenohumeral joint, right? So that's your humerus, yeah. And then you've got your greater tuberosity, and actually in between here, you've got your bicipital groove, right? And your biceps tendon attaches all the way like this and goes all the way down like so. So that's just a little bit of anatomy for you there. Then you've got your lateral acromion, which is over here, and you've got your acromioclavicular joint. And actually, in reality, that should really align with one another. Now, you can get a situation where you get it looks slightly out of line. So you can have it like looking like this, but then it just depends on like which angle you're looking at, because I've kept them aligned. But then if you kind of, look at it at this angle, to you, my hands look out of line, but they're not out of line. It's just the camera angle, right? And that's actually what happens. So if it looks really subtle, then I'd be careful about calling acromioclavicular dislocations. But in this particular situation, they're so far apart. I mean, there's no other possibility of anything else that could be. So someone says clavicle fracture. Fair enough. Let's have a look and see. So obviously, in the context of what looks like is an acromioclavicular junction dislocation, what you can see, what you need to do is just draw a line like so, and that should really align like that, but it hasn't aligned. So when you're looking at fractures, what you need to do is understand that, generally speaking, when it comes to clavicle fractures, it's going to be the middle third. The middle third of the clavicle gets fractured, the lateral not so much, and the medial not so much, because the medial is so strong, it's very closely associated with the chest wall. You need to have quite a significant injury to be able to see a fracture. But in that case, you do still need to be able to draw a line like so. And I actually think that line looks very, very normal. And then going along here, it doesn't look like there's any sort of fracture along the clavicle at all. And the distal clavicle looks okay as well. So the clavicle itself doesn't look like it's fractured. But what you do have is this very abnormal appearance to the acromioclavicular joint alignment. Now, what actually happens is that you've got these two ligaments. You've got your trapezoid, and you've got these two ligaments, the trapezoid and conoid ligaments, that attach to the acromioclavicular, the acromion sitting over here. And so what can happen is that these ligaments can get torn, and then they might need to go in and do some surgery to bring that back into place. What can sometimes happen is, because they attach to these regions over here, you can actually get avulsion injuries. So you can actually get an avulsion coming off like this and like this. So when you get these quite significant acromioclavicular junction dislocations or subluxations, then it is worth just having a look to see whether you can see any avulsion injury, because then that will tell you, like, 100% this person's got this ligamentous injuries, and they're called the conoid and the trapezoid. Trapezoid, I think it is, ligaments are attached to the acromion over here, keeping that clavicle down. So being radiologists or reporting radiographers or any sort of health professional, when someone's got a significant injury like so, you do want to have a look and make sure there's no evidence of any rib fractures. And in this particular situation, we've got no rib fractures, and we don't have any evidence of, I meant the coronoid process. Yeah, the coronoid process. So I might have said the wrong thing. So the coronoid process over here and attaches to over there as well. So thank you for telling me that. But yeah, you also just want to make sure there's no evidence of any rib fractures and no pneumothorax either, because I've seen that be missed. So just one more thing I want to tell you guys is this Y view, right? And so it's really important when you do the Y view is to literally draw that Y. And then once you've drawn that Y, you also want to try your best to try and draw the humeral head and make sure there's an overlap with the humeral head and that Y. Sometimes you may have a situation where the humeral head does this, like it's kind of slightly internally rotated, but it's still facing that sort of middle of the Y. Still facing that middle of the Y, or there's a little bit of overlap. You don't always get the perfect image where you kind of have that proper little light bulb sitting in the middle of that Y, but sometimes you just need to go with the idea that it needs to be facing in the correct direction. There needs to be a little bit of overlap between the middle of the Y, and then you can call dislocation, that kind of thing. In this particular situation, we don't have any fractures of any of the ribs. We don't have a concurrent pneumothorax, and we don't have a dislocation, but we do have is a significant subluxation of the acromioclavicular joint. Right, so that was case 4.